I'm Wally Fletcher, and I'm chair of the board of our Philadelphia School of Psychoanalysis. And we're welcoming you to this fifth in our series of anniversary lectures, this one on the future of psychoanalytic supervision. At the Philadelphia School of Psychoanalysis and our clinic, the Consultation Center, we're celebrating 50 years of providing modern psychoanalytic training and community mental health services to students, clinicians, and clients of wide diversity and need. Our series is titled Modern Psychoanalysis, Adaptations and Advances, to emphasize our commitment to the ongoing evolution and advancement of psychoanalysis as a profession and as a provider of therapies of depth, insight, relationship, and inclusion for people of all sorts and conditions. This afternoon, it's our great pleasure to welcome back Dr. Nancy McWilliams as our presenter. She's well known to many of you, I'm sure, but in brief summary, Nancy McWilliams teaches at Rutgers University's Graduate School of Applied and Professional Psychology and has a private practice in Lambertville, New Jersey. She is author of Psychoanalytic Diagnosis, Psychoanalytic Case Formulation, Psychoanalytic Psychotherapy, and the newly arrived Psychoanalytic Supervision. She has also edited or contributed to several other books and is associate editor of the Psychodynamic Diagnostic Manual, which was published in 2017. She's a former president of the Division of Psychoanalysis 39 of the American Psychological Association and is on the editorial board of Psychoanalytic Psychology. A graduate of the National Psychological Association for Psychoanalysis, Dr. McWilliams is also affiliated with the Center of Psychotherapy and Psychoanalysis of New Jersey, and she is on the board of trustees of the Austin Riggs Center in Stockbridge, Massachusetts. Like many of you, I have followed Dr. McWilliams' work since the publication of her groundbreaking book, Psychoanalytic Diagnosis in 1994. There's so much to praise about her contributions, but above all, I think of her as one of the most important interpreters of psychoanalytic wisdom and treatment in a generation or more. She communicates the essence of psychoanalysis in ways that translate meaningfully and practically for mental health professionals of many persuasions, disciplines, and cultures. She is a gifted teacher, clinician, and devoted advocate for therapies of depth, insight, relationship, and inclusion in the often unfriendly environment of increasingly manualized and falsely touted evidence-based treatment. In that regard, she's a significant contributor and advisor to the Psychotherapy Action Network, of which our institute is also a member. Those of us who have benefited from her series of textbooks on psychoanalytic psychotherapy are eagerly taking in her latest text on psychoanalytic supervision. I'm enjoying it very much. One of my favorite chapters is the last one, which is especially addressed to new supervisees who may have little idea of what to expect of a truly maturational supervisory relationship, some who may have even been injured by unhealthy ones. I'm looking forward to sharing and discussing this chapter with my own supervisees. So thank you, Nancy, for being our guest and model teacher this afternoon. And I will turn it over to you.
Thank you so much. My audio's okay and my video's okay from your perspective? Okay, thank you, Jim. Thank you to Ellen Wright and Lisa Coriel and Marie Hartke and the people who were interested in my coming here. Thank you especially for that lovely introduction and for asking me to speak at this celebration of the 50th anniversary of the Philadelphia School of Psychoanalysis. Congratulations to you all. When I was asked to give this talk, I had recently finished writing the book about psychoanalytic supervision, and so the organizers suggested that I speak today on the future of psychoanalytic supervision. I have enjoyed organizing my ideas on this topic, and I hope you'll find them thought-provoking. Let me first talk about my concept of psychoanalytic supervision. I had come to the idea of writing a book on psychoanalytic supervision and consultation as distinguished from other mental health traditions that embrace the obligation to educate, guide, and support therapists, partly because I've been critical of how the clinical mentoring process is increasingly being defined by major professional organizations such as the American Psychiatric Association and the American Psychological Association. I was troubled by trends, as Wally referred to, that equate supervision with skills training or teaching competencies or monitoring technical mastery, often associated with application to patients of manualized treatments developed in psychology labs that have little relationship to naturalistic psychotherapy conditions. The fate of psychoanalytic supervision is intimately connected with the fate of psychoanalysis and the psychodynamic therapies. As I and others, for example, Robert Bornstein, Enrico Gnalati, and Jonathan Shedler, have warned, the future of psychoanalytic therapy is threatened in the current era by forces way beyond our control, including insurance companies, governmental agencies, pharmaceutical corporations, and some academic groups that misunderstand and devalue our whole body of knowledge and clinical wisdom. So in this lecture, I'm inevitably talking about the future of both. I want to articulate and preserve a conception of supervision, not as passing on specific technical skills, but as facilitating the emotional and professional maturation of the therapist. In psychoanalytic communities, I think it is generally assumed that ideally, supervision initiates a lifelong personal evolution marked by increasing emotional honesty, expanding capacities for reflection on one's own subjectivity and that of others, the practice of containment and clinical discipline until those processes operate organically, and the internal access to a deeply integrated therapeutic knowledge base. The ambiance of contemporary psychoanalytic supervision is, with few exceptions, notable not for indoctrinating clinicians in a particular style of work, but for trying to help analysts in training become their best therapeutic selves. In my experience, and consistent with the findings of the rather scant research on the topic, psychoanalytic supervisors tend to emphasize the impossibility of being right, the need to learn from the patient what is helpful, the inevitability of limitations and blind spots in the therapist, the informational value of the supervisee's emotional experience of the patient, and the usefulness of attending to the so-called parallel process, a phenomenon that Rudolf Eckstein and Robert Wallerstein identified in 1958 in the first major empirical study of supervision. The discovery of the parallel process was the original insight in a long line of observations of what we now conceptualize as right brain to right brain affect transmission. In this case, the fact that emotional currents between supervisor and supervisee often echo core dynamics that emerge between therapist and patient. In 1979, Roy Schaefer described this process of maturation and integration in terms of the development of a therapeutic second self. I quote, "Because inevitably one is working with one's own personality, even after one has achieved the desirable subordination of personality to the psychoanalytic method, one must confront the question of what sense it makes to speak of psychoanalytic technique, And does the idea of technique somehow distort or spoil what is the more truly human aspect of psychoanalytic work? It does have to be recognized that analysis does not work well unless it is carried out under some constraints that define it as a method and that transcend questions of personality. One might speak of guidelines rather than constraints. But I want to emphasize another set of considerations in this connection. In our best work as analysts, we are not quite the same as we are in our ordinary social lives or personal relations. In fact, we are all often much better people in our work, in the sense that we show a greater range of empathy, acceptance, affirmative outlook, and goal-directedness. This observation suggests that there is a kind of second self which we develop. The second self is not and cannot be discontinuous with one's ordinary personality, yet it is a special form of it, a form that integrates the constraints required to develop an analytic situation and one's own personality. End of that long quote. Let me back up a bit and show you a few orienting slides to what I've been working on. Let me share the screen here. Okay, hope that's coming through all right. Here's my obligatory conflict of interest disclosure slide. There's the book I've been working on. Why I wrote the book. I've already talked about how I felt there was a need for integration. Talked about that in other books, and very often there are a few books on supervision that are from a particular psychoanalytic point of view, a relational point of view, for example, a classical point of view, but we needed an integrative book, I think. I also wrote it because I realized that training programs are increasingly under pressure to provide courses in clinical supervision. So I thought those programs that were more psychoanalytically friendly might appreciate an integrative book on psychoanalytic supervision. Third, what I've just talked about is a counteractive to what I see as an overemphasis on skills training and a focus on technique without the contextualization of technique within a broader educational and professional developmental focus. And because my friend Malin Fors, whose book on a grammar of power in psychotherapy you may be familiar with, she urged me to write a book about supervision and consultation. And then COVID came along and it became my quarantine project. There's the outline of the book. I give an overview, some historical background. I go over what I think are the vital signs that supervisors monitor and help their supervisees to monitor, and I'm going to spend a little more time on that in a minute. Individual supervision, group supervision, a chapter on ethics, a chapter on the particular challenges of supervising in the fishbowl of psychoanalytic institutes, a chapter on individual differences and specific challenges, and the chapter that Dr. Fletcher just talked about, how supervisees might be able to make their supervisory experiences as useful as possible. I'll just run over the history a bit here, noting that Freud said little about supervision. He was notably non-dogmatic about how therapy should be done, beyond urging us not to have sex with our patients and not to try to be prophet, saver, or redeemer, which is, I think, a very important comment of his. And for me, that's much more of a temptation than any sexual temptations with patients. One always wants to be better than the patient's parents, to compete with the other influences on the patient, to somehow believe that I can save them, rather than the more modest ways that we help people understand themselves better and live a better life. Freud did set the tone that the best education for a therapist would be the person's own experience in psychoanalytic treatment. Two different models were clashing with each other for quite a while in the middle of the last century, in the 1930s and 40s especially. The Berlin model that Adolf Eichmann elaborated, and that's the familiar, that has kind of won the day. That's the familiar model of personal analysis, so-called control analysis or supervision, and coursework. The Budapest or Hungarian or Ferenczi model was looser. For example, in the Budapest model, the assumption was that the best supervisor for you would be your own therapist, because who knows you better. That was eventually critiqued because it does involve the complications of a somewhat dual role, and it gets in the way of supervisees becoming influenced by people other than their own analyst. So we've pretty much settled on the Berlin model in almost all the analytic institutes worldwide. 1958, as I mentioned, was an important year because we first began to see research on supervision. Eckstein and Wallerstein at the Menninger Institute did a very important study. And that book is still a very lovely book, the 1958 book that they published about it. We eventually came to put our emphasis on the supervisory alliance as psychoanalytic supervision evolved. Joan Sarnak talks a lot about that in her 2015 book. We've also begun to see a decent empirical literature on supervision. There's a group in Oslo that's studying it very carefully. There's a group in Columbia that's studying it very carefully. There's a guy in Texas, Charlie Watkins, who has studied supervision across orientations, but his heart is with psychoanalysis, and he's done some wonderful work. He has a book out that's a tome. It's huge and heavy, but it's got some wonderful articles in it. There are several historical tensions in the literature on supervision, and in my objectives for the day, which I have to submit for anybody having continuing ed credits, one of the things I said was that you could, at the end of this, articulate three historical tensions, and here they are. One is with supervision, how much is it about just teaching? And the treatment part, you go to your own analyst for that. Or how much is it integrate teaching and treating? I think in reality, it's not possible to teach at any kind of deep level without it having a therapeutic effect. But supervisors have differed into how much they try to keep those roles completely separate. I should say that all of these tensions, I think, are somewhat false polarities in that it's not really always a question of either or, but more what combination. This is a big one, the second one, and this is what a lot of my talk is about today. Is psychoanalytic supervision about passing on techniques and skills, or is it a general fostering of the supervisee's growth? And I vote for both on that one, but that's been quite a controversial area of discussion over the years. And more recently, should psychotherapy be taught as a science or as an art? That is a big controversy in the mental health world beyond psychoanalysis, but it exists within psychoanalysis too. There are people who argue that if you emphasize the art of it too much, you're not going to be teaching the body of knowledge about interpretation or countertransference awareness or understanding of enactment and some of the more technical approaches. So those are some historical tensions. I suspect they will always be there. I'm going to argue later on that we've made a category mistake with psychoanalysis. But this is Gilbert Ryle, the philosopher. But let me go back, stop sharing for now, and speak a little bit more, and then I'll come back to this. So looking back at those last two controversies or tensions or polarities, teaching techniques or fostering a growth process, and science versus art. These last two tensions in the literature are interrelated, and I'd like to expand on them. In the quotation I read from Roy Schaefer, you'll note his clarity about how supervisees do need to learn a method, or at least they need to be taught the conditions that make a psychoanalytic process possible. Especially when people are first learning to do psychotherapy, they require some kind of a roadmap, a core set of rules and principles. Beginners in our field need more specific guidance than the general supervisory comments, which my students are always critiquing me for. Well, it all depends. As Jonathan Slavin observed about his supervisees many years ago, people in training often seek rules of procedure from us because otherwise they feel overwhelmed by the magnitude of the task of helping people who are all unique and who suffer in profoundly diverse ways. An additional reason for putting some supervisory emphasis on teaching specific clinical skills is that it is important for psychoanalysis as a field to define the elemental aspects of our work so that its practitioners do not descend into what Freud called wild analysis, where boundaries disappear and anything goes. Psychotherapy has a lot in common with normal social conversation, but it is not equivalent to it. It has its own vocabulary with which a student has to become fluent. As Erwin Hoffman noted, you have to know the book before you deviate creatively from the book. In other words, prose precedes poetry. Research endeavors, which are critical to the survival of psychoanalysis, may also require supervision that emphasizes adherence to certain rules of technique. Analysts who develop a method for working with particularly challenging or diagnostically specific groups of patients will not be taken seriously these days if they offer no empirical research supporting their ideas. Supervisory attention in such cases may have to be on following scrupulously a certain method. Manualization, something more and more academics are urging therapists to do and telling insurance companies that we should do or else forego reimbursements, don't get me started, is a research requirement, not a clinical one. Manualization ensures that the technical approach you say you are investigating is in fact the one that all the clinicians in the relevant study are implementing. Therapists in Otto Kernberg's Personality Disorders Institute, for example, share a clear conception of the technique of transference-focused psychotherapy for severe personality disorders. Supervisors in that group encourage therapists to follow TFP rules of technique quite closely, especially when the effectiveness of TFP is being studied empirically. Clinicians learning mentalization-based therapy, another approach with a growing empirical literature supporting its psychoanalytic method, are similarly trained in a theory-derived technical algorithm. But in most clinical settings, insistence on compliance with narrow technical prescriptions has not been typical of psychoanalytic mentorship. When it has, the supervisory relationship has often suffered. In ordinary practice, over time, supervisees need more support for their creativity than for their compliance. There is empirical evidence that as we develop as therapists, we become less rigid and more integrative, and that in the process, we become more therapeutically effective. One study done way back in the 1960s found that students of therapy were measurably better clinicians before they had been trained how to treat patients. Their graduate training made them self-conscious and stilted in their first years of practice. With experience, however, they eventually became good at, as good at, and better than their natural intuition had made them before their teachers' pedagogical efforts had disturbed the spontaneous warmth and curiosity that originally characterized their responses to patients. This observation about natural relaxation into a therapeutic presence extends to the loosening of one's adherence to certain schools of psychoanalytic thought as well. With the encouragement of wise mentors, most of us become gradually less single-mindedly identified with only one theoretical orientation. We become aware of some limitations and lacunae in our preferred theory. We notice variability within our tribe in how the theory is implemented in therapy. And we become humbled by finding clinical help from concepts that originated in other theoretical schools. Eventually, we make peace with the diverse influences on us and work out a way to be our own kind of analyst of whatever orientation or mix thereof that honors our sense of agency, our experience, our interests, our studies, and our attachments. This intimate process is different for each individual and cannot be predicted at the beginning of a mentoring relationship. As the different schools of thought within psychoanalysis mature, a certain evolution happens at the systemic level as well. Approaches that were once novel or deviant or paradigm shifting slowly assimilate concepts and techniques from other psychoanalytic orientations or reinvent similar ideas in the language of their own preferred paradigm. Because psychoanalysis embraces many different perspectives, theories, metaphors, and technical preferences, this process is challenging both for communities committed to a particular school of psychoanalysis and for individuals in training as they try to find harmony in a cacophony of inharmonious voices. Early in our growth as analysts, I think most of us manage this complexity by identifying with one theoretical orientation to the exclusion of others. We may see ourselves, for example, as Freudian or Jungian or Kleinian or Lacanian or Cahusian or interpersonal or ego-psychological or modern or control mastery or relational or something else. This choice is influenced by people in the field whom we admire, including our analysts, teachers, and supervisors, and the writers to whom we find ourselves resonating. It is influenced also by the patients we first work with and by our individual temperaments. A recurrent theme in my new book is that psychoanalytic supervision is not reducible to the teaching of particular strategies or rules. Instead, passing on the torch in our field involves the invitation to supervisees to extend their individual personalities and bend them towards psychoanalytic aims. Psychoanalytic mentors impart to their trainees a whole gestalt, or what I've sometimes called the psychoanalytic ethos, or the psychoanalytic sensibility, or what Schaeffer called the analytic attitude. This sensibility includes the valuing of self-understanding for its own sake, not simply for its role in symptom reduction. The habit of honesty, in Michael Guy Thompson's words, an orientation of empathy and compassion, an egalitarian collaborative attitude toward the patient, a commitment to growth in agency and personal responsibility, acceptance of normal dependency, and respect for others as subjects rather than objects. Sandra Buchler has suggested similarly that the core ideals guiding psychoanalytic therapies include evoking curiosity, inspiring hope, acting with kindness, promoting courage, manifesting a sense of purpose, creating emotional balance, bearing loss, and developing integrity. I've mentioned the value of starting out as a psychoanalytic therapist with a clear theoretical roadmap. We typically expand and modify that map as we mature under the supervision of analysts who nurture that expansion, whatever their own theoretical preferences. Schools of analytic therapy become inhibitory to professional growth only when they drift toward fundamentalism, when mentors convey to supervisees that their sect is the one true faith. Some psychoanalysts have erred in that direction, framing supervision as a matter of teaching what they would do or say to a patient, or what they believe Freud or another idealized psychoanalytic exemplar would do or say, and insisting that the supervisee follow suit. That pedagogical strategy hasn't usually worked out well. While I was writing the supervision book, colleagues who learned about my project often volunteered horror stories about their early experiences in supervision, sometimes dating back 50 years, yet still remembered with pain. Usually, these accounts involved working with someone who insisted on the supervisees following a particular script or behaving according to a particular model, despite the fact that the trainee's intuition was screaming that this would be the wrong thing to do. I have a few memorable horror stories of my own, though they do not, thankfully for my own identifications, include sins committed by psychoanalytic mentors. For example, I briefly had a supervisor who insisted, contrary to all my best understandings of what my patient needed, that I write this troubled young woman a letter telling her that she was manipulative. He subscribed to an elaborate ideology about the value of increasing the patient's anxiety and tended to see confrontation as the most valuable tool in the clinical toolbox. I later came to appreciate that there are many adherents to particular styles of treatment who behave, despite Abraham Maslow's long ago warning, as if the fact that a hammer is a good tool compels the conclusion that every clinical situation one encounters is a nail. One can still find psychoanalytic supervisors who feel that a particular technical approach is the most important thing to pass on to a trainee. Often they idealize one version of analytic practice and devalue other ways of working as deviations from what they see as real or true psychoanalysis. In fact, Freud himself contributed to this tendency when he referred to the method he had developed for treating neuroses as pure gold, and opined that this approach might have to be modified with patients who differed substantially from the people who tended to come to him for treatment. In a metaphor that still haunts post-Freudian psychoanalysis, he characterized the process of adapting analytic ideas to the needs of individuals with non-neurotic diagnoses, or whose circumstances prevented their coming multiple times a week using the couch and free associating, as diluting that pure gold with alloys. One of my own supervisors, the one who influenced me most deeply and permanently, trained at the National Psychological Association for Psychoanalysis in the 1950s. He described one of his control analysts, an unfortunate term for supervisor, I think, as being excessively controlling. This man conveyed the attitude, "I'll tell you how it's done." He spelled out what the supervisee should say, leaving little latitude for the trainee's creativity or intuition. My mentor left that supervisor on the grounds that he did not feel there was adequate space for integrating the teacher's ideas with his own individuality, and he promised himself to put his own eventual supervisory emphasis on helping people to find their own natural psychoanalytic style rather than urging them to adopt his. I was later the beneficiary of that view. It will be of interest to people in the Philadelphia school that the supervisor in question was Hyman Spotnitz. Before you worry that I am impugning the architect of modern psychoanalysis, let me say that I think Spotnitz can be forgiven for some heavy-handedness early on. When my mentor sought him out, he was inventing a whole new style of analytic treatment, articulating an approach for patients more seriously disturbed than those who were diagnosably neurotic. At the time, his technical innovations, notable for their strategy, which was new, of joining the resistance, were referred to as paradigmatic psychoanalysis and were provoking heated controversy. Spotnitz was often challenged to defend his ideas as if they amounted to analytic heresies. If in response, he became a bit dogmatic in those years, it is hardly surprising. Spotnitz's eventual legacy has surely been in the direction of helping therapists in less controlling ways and encouraging them to be open to all their darkest places. In modern psychoanalytic training, candidates are urged, like their patients, to say everything, to own without shame or defensiveness their own hostile reactions to patients, teachers, and supervisors, to expand the emotional space with clients rather than squeezing them into one-size-fits-all interpretation. It is my impression that today most supervisors trained in modern psychoanalysis leave a lot of room for individuality and art. I mentioned my supervisor's experience of Spotnitz partly because I thought it would interest you to hear a story about the early days of your founder. I'm getting long enough in the tooth now to gossip about the old days, which I think is one of the irresistible vices of psychoanalysts from the beginning of our movement. But primarily because I'm making the point that even supervisors who later in their own development as mentors support the individuality and creativity of the next generation of clinicians may adopt a directive, opinionated style in their earliest work as supervisors, especially if they're feeling under attack by colleagues with different affinities. Having noted that some analysts may be vulnerable to supervisory rigidity, let me repeat my impression that as an orientation, psychoanalysis has been notably less rigid than approaches that emphasize mastery of particular interventions. This relative lack of technical dogmatism reflects not only the general ethos I have mentioned, but also our implicit philosophy of education. Psychoanalysts take internal resistance as a given and do not assume that individuals can readily do what an authority tells them to do. They know this about their patients and they know it about their supervisees. I remember identifying strongly with Theodore Reich's confession that he was unable to learn anything on the basis of authoritative claims. Instead, he had to master all he knew by questioning authority, trying things his own way, and learning from his mistakes. Not all supervisees are as characterologically oppositional as Theodore Reich evidently was, or I am for that matter, but none of them want to be spoon-fed with no chance to think about what is in the spoon either. When supervisees do submit to supervisory fiats, their patients are likely to experience them as inauthentic because the technique they are trying to compliantly implement has not been integrated into their natural presence. After they have internalized multiple influence and have come to their own synthesis of psychoanalytic knowledge and practice, their clinical style will be more organic and will be felt as more authentic by their patients. When I speak of the future of psychoanalytic supervision, it is this messy, hard to measure, complicated mentoring experience that I am concerned with preserving. I recently heard an expert on training Olympic athletes distinguish between transactional and transformational coaching. The former is controlling, prescriptive, and comes from a position that the expert knows. The latter creates a relationship that allows the athlete's natural excellence to emerge in its own way. This is the kind of contrast I'm making between supervising psychoanalytically and directing one's mentee not to deviate from a manual. It is the difference between painting by numbers and approaching a blank canvas with a vision. Let me apply some of these ideas to the realm of professional quality control and ongoing clinical growth. In efforts to ensure that therapists are abreast of important discoveries in mental health, a slow crawl toward more ritualized, less reflective conceptualization has taken place around us. We are seeing more bean counting and less attention to matters of substance. The task of submitting a proposed program to an overview committee, to take an example close to my heart, so that it will be deemed sufficiently worthy of continuing education credits, has become so burdensome that it takes me at least a couple of hours every time I organize a new lecture or workshop. So-called learning objectives must be measurable, with the comical result that one is not allowed in the learning objectives to use the verb learn, as in, at this workshop, therapists will learn new ways of conceptualizing traumatic experience. Instead, participants have to be predicted to be able, after a program, to describe or enumerate or articulate or some similarly active verb that lends itself to easy measurement. This bureaucratic burden has over the years become ever more onerous. I'm now asked to submit not only title, description, bio, learning objectives, and scholarly references for what I'm going to talk about, but also an argument for what is new about what I'll talk about, what practice gap it fills, how it may relate to issues of diversity, what level of experience in its audience members the talk presumes, and a disclosure that I have no conflicts of interest. Most recently, I'm being asked, in addition, to devise and submit 6 multiple choice questions for each learning objective. All these demands come with extensive and sometimes confusing small print on how to comply. Of particular interest to a psychoanalytic group, the guidelines of the American Psychological Association now forbid including references supporting the content of the program that are more than 10 years old. Not only does that mean we cannot officially admit that much of our teaching draws from decades-old psychoanalytic clinical thinking, but we must also eliminate from our list of empirical studies any research findings that were published more than a decade ago, regardless of the quality and the relevance of the work. I think all these processes tend to corrupt our thinking about clinical education, much as the requirement by insurance companies to frame our work in terms of potentially measurable treatment goals can gradually corrupt our sense of what psychotherapy is all about. When the APA conducts its periodic evaluations of psychology graduate programs, internships, postgraduate fellowships, the site visitors are much more interested in what most of us would consider trivia, because it is measurable, than in questions that are at the heart of the training endeavor. These site visits are grueling and often feel arbitrary and nitpicking to the professors, administrators, and staff members who have to comply with burgeoning bureaucratic demands at the cost of time that could go into meatier duties like teaching, research, and administrative support. My colleague Elliot Jurist remarked to me, as his clinical psychology program at the City University of New York was being evaluated by an APA committee some years ago, they don't seem to care that our students are doing wonderful, sensitive work with complex, multi-problem, traumatized families who live in poverty in the inner city. They care whether their coursework included 2 units of developmental psychology. My husband, Michael Garrett, who was for many years the director of psychiatric residency at a New York public medical center, has told me the following story. Periodically, especially after any highly publicized failure of some city hospital, his staff would be visited by governmental overseers entrusted with quality control and improving safety. Despite the fact that there had been no suicides on their unit for many years, the head site visitor insisted that his department divest the inpatient unit of all looping opportunities. That is, remove any projections from walls, such as television attachments or even doorknobs, from which a patient might commit suicide by hanging. With the money they spent on eliminating looping opportunities, they could have hired another social worker to assist in actual patient care. This kind of bureaucratic redefinition of what ultimately matters is inherently inconsistent with psychoanalytic understandings of how learning and change come about. And developments like this, operating cumulatively, are slowly undermining our ways of working in both therapy and supervision. Let me apply my perspective on psychoanalytic supervision to the realm of ethics. A primary obligation of any clinical supervisor is to oversee their supervisee's integration of ethical principles into their therapeutic practice. For this purpose, our organizations promulgate overall moral tenets by which our profession should conduct its work. In psychology, these include beneficence and non-maleficence, fidelity and responsibility, integrity, justice, and respect for people's rights and dignity. In psychiatry, they are instantiated in the Hippocratic Oath. But in practice, the ethical issues taken up by our gatekeepers and governing bodies are often about narrow questions of risk management. Boards to whom patients can complain are rarely led by practicing clinicians, and their members tend to have very concrete, literal interpretations of their relevant code of ethics. The moral complexity of many treatment issues can morph into the naive conviction that merely by following the rules to the letter, all will be well. Under contemporary pressures to cut costs, even fairly straightforward rules are often honored in the breach, with associated rationalizations intended to protect therapists from guilt and patients from outrage and despair. We have an ethical proscription against abandonment, for example, which does not seem to have counteracted current pressures to end treatments that a particular patient's attachment history strongly attests should be continued. These forced terminations fly in the face of the empirically documented centrality of the therapeutic relationship to treatment outcome. As long as one provides a patient with a list of alternative sources of help, irrespective of the quality of such services, one cannot be held accountable for abandoning patients that an insurance company or government deems healthy enough to stop good work with a particular clinician. I'm not arguing that we don't need any limits on psychotherapy expense. I am saying that the message that a limited treatment is all a person needs is intellectually dishonest. Rather than being a matter of by-the-book adherence to professional regulations, ethical issues in clinical practice can be as complicated and messy as the process of learning to be a therapist. Supervisors can find it quite challenging to help supervisees with some of these vexed questions. Let me offer an extended vignette from my recent book that illustrates the complexity of a psychoanalytic therapist's ethical dilemma. A colleague in South America who occasionally confers with me about his cases asked for my assistance in deciding how to handle issues that had arisen in his work with a woman whom he had taken into treatment several months earlier. She had come for relief from recurrent depressions unalleviated by medication, and for help improving her troubled relationship with men, which she attributed to having been brought up without a father. My colleague had felt an immediate sense of affection toward this client. She was poised and attractive And in their initial session, the thought had passed through his mind that she resembled the beloved old friend of his who lived far away, whom he hadn't seen in years. The patient connected her depression with several experiences of male teachers, bosses, and lovers in which she had found herself eventually feeling neglected, misunderstood, and/or rejected. Her current intimate relationship with a man felt fragile to her. At the time the therapist called me, he and the patient had been meeting twice weekly, and their working alliance seemed solid. This woman, now a professor of literature, had been raised in dire economic circumstances. In her family of origin, there had been no father or paternal figure. Her mother had told her that she was the product of a one-night stand and that she had no idea where her father was now. My colleague noted to himself that this history shed valuable light on his client's expectation of rejection, depressive self-hatred, and recurrent problems with men. The therapy was going well, and the clinician was beginning to address the patient's transferential fears that he, the therapist, did not care about her and would eventually reject her. In their session preceding his call to me, she had spoken for the first time of a brief period after college when she had been an academic intern in another country. Her field of study was highly specialized, even esoteric. She had thought there would be no money for the internship and was surprised when her mother somehow came up with funds. A vivid memory suddenly invaded my colleague's mind. His old friend, the one the client resembled, had long ago confided, while drunk, that he had once cheated on his wife, with the result that he was the biological father of an adult daughter who lived near the city where my consultee now practices. He stated that the girl's mother knew where he was, but had contacted him only once to ask him to pay for their daughter's internship in the obscure academic area and distant country my colleague's patient had mentioned. In return for this financial support, the mother had allowed him to view the young woman from a distance and had pointed out her resemblance to him. The age, field of study, and current residence of my supervisee's patient all dovetailed exactly with his old friend's story. That's the data. As any experienced analyst can attest, such uncanny coincidences are less rare than one might think. More ordinary dilemmas of a similar nature are not uncommon. Intrusions on treatment by information coming from outside the office cause clinical headaches with which therapists are painfully familiar. Most of us have been in the uncomfortable situation of having become privy to critical facts about a client that the client does not have. This can happen even when we are being scrupulous about boundaries. For example, we are working with a person who turns out to know someone else in our caseload who mentioned some pertinent data about which both we and the other client had been ignorant. Or we learn through some personal grapevine that a patient's partner is having an unsuspected affair. My supervisee knew with almost complete certainty who his patient's abandoning father was. What should he do? Should he tell her? Supporting that option is the fact that secrets tend to undermine the free inquiry that is critical to the therapy process. If I am innocent of knowledge that my patient's husband is cheating and I hear from her about peculiar changes in his behavior, I might ask, have you ever considered the possibility that he's having an affair? With insider knowledge, however, this question is no longer innocently exploratory. I would hence be unlikely to ask it. The unbidden knowledge inhibits my freedom to raise possibilities. It is extremely burdensome to know something important that a patient does not know, and in that situation, one inevitably feels vaguely dishonest with the client. Supervisees frequently bring up such issues with their mentors. My South American colleague was facing a challenging moral dilemma. He had a long-standing obligation to his friend, to whom he had pledged never to reveal his secret. But he had a pressing professional commitment to the ultimate welfare of his client. It might be argued that one's duties to a patient override a promise made long ago to a friend. But the therapist had no way of weighing the potential negative consequences of betraying his friend's confidence against the potential negative effects on his patient, and for that matter, on her mother and her mother's family, if he should opt to tell her what he knew about her probable paternity. The Hippocratic principle, first do no harm, seemed to militate against revealing what he knew. And yet, what if, at some future point, the client were to talk with the therapist about an intention to find out who her father is? What if she wanted to search for him and meet with him? How could the therapist support such a plan in good faith? Absent the connection with his friend, he might have taken the general psychoanalytic position that knowledge, however painful, is preferable to ignorance, and thereby implicitly supported her search. With what he knew, however, he had a certain emotional stake in her ignorance, one that could compromise his usual professional stance. What if the patient were eventually to discover her father's identity and learn from him that her therapist had been his friend and confidant? Would she be appalled that the therapist had never revealed this? Would she feel as betrayed by my colleague as she might already feel by her father for having left her, and by her mother for having lied to her about not knowing his whereabouts? Would such a revelation undo many years of devoted therapy? Such disasters have been known to happen, and most of us would put a high priority on preventing them. Real ethical dilemmas are often complicated in these ways. Given that he and I could not predict the consequences of the disclosure, the therapist and I decided he should not say anything. Unlike a decision to tell the secret, which could never be undone, that position could be changed in the future. We rationalized that because it was only 99% probable that his friend was the patient's father, he could not ignore the 1% possibility to the contrary. It remains to be seen how his forthcoming work with this woman will be affected by his private knowledge, but at least he knows I'm available to share the burden of future decisions that may arise about this patient's best interest. An interesting feature of this quandary is its conflict between personal and professional moral claims. The destruction of a valued friendship in the name of clinical ethics is certainly not morally neutral, but it can happen when therapists see no alternative to putting the client's welfare above a personal relationship. I'm sure many of you can think of similar dilemmas in which clinical right and wrong were not starkly contrasted, as in the Kleinian paranoid schizoid position, but where each potential resolution had both positive and negative ethical implications. It is these kinds of situations that the contemporary appetite for narrow rule following ignores. Let me run through some other slides, which I know some of you have seen in a different context or an earlier version. These are ideas about overall mental health about which I've been thinking for many years, and which I eventually decided to import into my book on supervision. These are the areas I believe good supervisors teach psychoanalytic therapists to monitor as mentor and mentee assess together whether a treatment is going well. So let me go back. Okay, I raised the issue of a category mistake. This is background for what I'm about to talk about. If you want to do a particular kind of outcome research of a short-term treatment, or a long-term one for that matter, but there's usually not money for that, you first of all have to isolate your variables. This is a research requirement. You have to choose people. If you're studying a particular treatment for a particular disorder, you have to choose people with one clear disorder, not comorbid with anything else. Clinicians call that cherry picking the subjects of the research. It's a research requirement. You have to take objective measures of observable symptoms to get a baseline to see whether therapy changes something. You have to manualize your interventions. that, as I said before, is a research requirement, not a therapeutic requirement. You have to limit the time period of the study, either because your grant is going to run out, or because you have to churn out a whole lot of publications of short-term studies in order to move toward tenure or promotion. Academics are under much more pressure than they used to be, and they seldom have any time for any clinical work. They have to churn out all these empirical studies. So naturally, they study stuff that they can master in the short term. And most importantly, for what I'm about to cover, if you're doing a certain kind of research, you have to evaluate improvement by changes in observable symptoms. Like, for example, you give them the Beck Depression Inventory if you're studying depression, and you see whether their symptoms have remitted after a certain number of implementing manualized interventions in the study. This is necessary for research, but we are seeing, the reason I'm calling this a category mistake is the idea of a category mistake is you're applying concepts that are naturally applicable to one field to a different field. I would never argue with people who say that clinical practice should be based on research, or based at least partly on research, and not just on an idealized mentor, for example, or an encouraging theory. But we're under this pressure from people who don't understand clinical practice very well to act as if psychotherapy is like research. So people are encouraging us to talk about people in these discrete categorical ways, to take objective measures at the beginning and the end of a treatment, to manualize what we do, to work short term, and to evaluate improvement by what you can measure in observable symptoms. And that's a category mistake. That's not a clinical approach to understanding people. So I've been putting together for years, and I know I presented a version of this to Ellen Wright's group quite a while ago. I've been thinking about what therapists think of as overall mental health, which I eventually construed as vital signs. We think about overall wellness much more than symptom reduction in psychoanalytic therapy. Not that we don't care about people being less troubled by symptoms, but we also know that symptoms come and go, and we're looking at larger stuff. Sometimes symptoms get worse in psychoanalytic therapy in the short term. If I'm very anxious about a new behavior that I've never tried before, and I get brave enough to try it, my anxiety is temporarily going to go up, even though I'm moving forward. If I had a terrible loss that I've been handling only with denial, and I begin to really grieve it and address what's been lost, I'm going to check more depressed on a Beck Depression Inventory, but I'm getting better. Okay? So I put together a list of 10 areas that we monitor, and that in this era, when students are brought up only on the DSM and the idea of symptom reduction being the pure gold of psychotherapy, we have to teach them to look at these larger issues. All of these concepts are psychoanalytic. Some of them emerged from prior thinking, and some of them have been reinvented by other thinking. But let me just go through them quickly. These are the areas where I think psychoanalytic therapists pay attention. Their supervisors teach them how to pay attention to these. They teach them how to understand that these things may be going on even when the patient is temporarily more angry or more resistant or more depressed. We want to help people increase their sense of safety, increase their self and object constancy, increase their sense of agency, increase their realistic self-esteem, increase their resilience and flexibility, increase their reflective function and capacity to mentalize others. We want to hope they'll be comfortable in both communal and individual ways of experiencing. We hope to help them find their vitality. We help them to accept what can't be changed, which leads to an attitude of forgiveness and an attitude of gratitude for what is. And we try to increase their capacity to love and work and play. And I'll go over these quickly. In terms of increased interpersonal safety, this is what Sullivan called security operations, Erickson called basic trust, John Bowlby called attachment security, Peter Fonagy has called epistemic trust. If you don't have that, you can't do much beyond that. So that is the first thing we tend to work on with patients. Do they feel safe with us? And we want to increase their attachment security over time. And according to the empirical research of what's his name, Philip Shaver at the University of California at Davis. Empirically, there are two ways that people change their attachment styles from one of the insecure types to a more secure type. Attachment styles, as you may know, are pretty consistent throughout the lifespan. If you test in the play therapy situation at age 3 to be someone with an avoidant attachment, and you take the adult attachment inventory in adulthood at 33, let's say, you'll probably still test as avoidantly attached. But there are two conditions in which people move toward more secure attachment. One is a love relationship of at least 5 years, a devoted partnership of some kind, marriage or some kind of reliable, loving relationship. And the second one is intensive therapy of at least 2 years. So we improve people's sense of interpersonal safety in treatment. These are some relevant references, and all these references, I start mostly with the psychoanalytic literature, and by the end I go into some empirical studies. This is a good book on attachment. I mentioned Philip Shaver's work before. Secondly, we want to increase feelings of continuity, personal going on being, as Winnicott would say, of what Erickson called identity integration, of what Margaret Mahler called self-constancy, of what Heinz Kohut called self-cohesion, what Philip Bromberg talked about standing in the spaces. We want our patients to be able to integrate good and bad aspects of themselves rather than splitting into all good or all bad, self and other designations. We want them to feel some sense of continuity with the child that they used to be. Some patients, when you ask them, tell me about your childhood, they either blank out completely or they talk as if there was some other kid that they no longer have any compassion for, who did all those things. Let me just check that. I just got a message that I had muted. Is that right?
That was my error. Sorry. Thank you.
Okay.
I'm glad you got that. Thank you.
All right, I'll go back. It was kind of a strange thing, thinking, oh my goodness, how long have I been talking to the screen? There are patients where you say to them, where do you see yourself in 5 years? And they look at you like a deer in the headlights. I don't know. They don't have a sense of being through time. And the other way we try to help them feel some continuity is with their body. A lot of people, especially these days, seem to treat their body as an alien other. They carve it up, they burn it, they starve it, or whatever. And it doesn't feel to them like them. It's It's dissociated from who they are. So that kind of increasing integration is a big part of psychoanalytic work. References. Increased sense of agency. Erickson called this autonomy, so did David Shapiro, so did Steve Mitchell. Internal locus of control is an academic area of study that captured this back in the 70s. Robert White, also back in the 70s, talked about effectance, the sense of having an impact. Albert Bandura from the social behaviorists talked about self-efficacy. Mostly in clinical work, we notice this sense in its absence when we work with a patient who doesn't have it, where you say to somebody, well, tell me what went into your decision to marry your husband. And they say to you, I don't know, it seemed like the thing to do at the time. You get the sense that the person doesn't have any sense of going through life with a sense of any kind of options or control or effectiveness. So we try to increase that in people. Increasingly realistic and reliable self-esteem. That's very similar to what Freud called a stable ego ideal, or Adler, who was way before Freud, onto the centrality of this area, feeling of adequacy. Rogers was onto this, positive self-regard, and of course, Kohut talking about healthy narcissism. What I mean by realistic, what the psychoanalytic literature means by realistic, is that your self-esteem is attached to realistically attainable goals. So it's unrealistic self-esteem if I believe that this lecture should be perfect, and if I've stumbled over a word, I'm terrible. You know? Or if I'm all inflated and I think that, you know, I'm God's gift to lecturing, and of course, you know, there's a problem with you if you don't think I've delivered just the perfect lecture. So either, you know, unrealistically inflated or unrealistically perfectionistic and thereby constantly self-critical is a problem. Reliable means that you can keep a sense of self-esteem even under criticism. If somebody gives you feedback that's not entirely supportive, that might tell you how you could improve, you don't fall apart. It's never not going to be a pang, but you can keep your sense that you're good enough and use the information to improve. You also aren't vulnerable, if you have reliable self-esteem, to being inflated by other people and manipulated based on their being able to suck up to your need to see yourself as superior. So those areas are increasingly problematic for people in a culture like this, where it's a mass culture, it's a global culture. People, especially during COVID, people don't feel very able to have realistic ways to evaluate themselves, and they feel very, very small and powerless in light of the larger world. So self-esteem over the decades has become, as we've globalized and as change happens so fast, it's become an increasingly central area of concern for psychotherapists and their patients. Increased resilience, flexibility, affect regulation, we've called that all kinds of things: ego strength, conflict-free sphere, maturity and flexibility of defenses. For example, we want our patients to use, not to be rigidly using the same defense all the time. You know, whatever happens to me, I dissociate. That's an inflexible defensive strategy. Or being pushed around by more primitive defenses and not having more mature ones. The primitive defenses being denial, primitive withdrawal, splitting, primitive forms of projection and introjection or projective identification, primitive extreme versions of idealization and devaluation, omnipotent control, primitive forms of dissociation, acting out, and somatization. I probably missed a couple, but if you're organized with those defenses, we want to help you develop a better repertoire of dealing with life. Resilience is what the empirical literature calls this area. Tompkins called it affect regulation. Crystal, an analyst, called it affect tolerance. Marshall Linehan called it emotion regulation. I like Elliot Juris' term, affect modulation. All of these things are areas where we're in there with patients, and we support the evolution of increased strength in these areas. The capacity to reflect on the self and mentalize others has a long history. It goes back to Descartes' notion of theory of mind. Can you imagine the separate subjectivity of somebody else? Martin Buber wrote about I and thou versus I and it, which is about reflecting the subjectness of the other. Freud talked about an observing ego being critical to psychological health. Frankl talked about a search for meaning. Insight has been widely used to capture this capacity. Self-reflection is the hot term these days, or reflective function. Jessica Benjamin talks about recognition of the other, and the patients need to feel recognized. Freud's idea of an integrated superego has elements of this as well. I think somebody's not muted who probably should mute. We're getting some background noise that's going to come through on the tape, so you might want to each check this out. A mature sense of morality is something Kernberg pays a lot of attention to, and Charles Taylor has written about psychotherapy as essentially a moral activity. This is all about helping patients be able to look at themselves and be able to appreciate others, and not to do what the Kleinians call projection of intent, meaning if you behave in a certain way to me, let's say you say something that hurts my feelings, even though you say it with good intentions. If I jump to, I feel hurt, so you were trying to hurt me, I'm doing projection of intent rather than trying to think about what you might have had in mind as separate. So patients who come in, like I've been giving this example for a while now. Years ago, I had a father come in to me and talk about his 9-month-old child. And he said, that baby really knows how to push my buttons. And he was serious. He couldn't mentalize a baby. He felt the baby was trying to torment him. That's a dangerous way to live. And we help people with that. There's the book by Juris who talks about modulation of affect. This is an important area. I'm basing most of what I say here on Sidney Blatt's work, but it's an old idea in psychoanalysis that there is a tension, a polarity between being self-concerned and being concerned for the other and the group, whether you call it introversion versus extroversion, which was Jung's concept, a very robust concept, by the way, that comes up again and again in all kinds of empirical studies of individual differences. Balint Ochnephil, lover of closeness, versus Philobat, lover of space. Immanuel Gent's beautiful article on the difference between surrender and masochism, that, yes, we all want autonomy, but we all want to surrender to something greater than ourselves as well. And if we can't do that, there's something wrong. Closeness versus distance, self-definition versus self and relationship, which comes out of Sidney Blatt's 35 years of empirical study of first of depression and then of other issues. Or you can frame this as individualism versus collectivism. One of the things that Western psychotherapists have to be very careful of is not pathologizing people who are from cultures that put more emphasis on collective responsibility and obligation than our highly individualistic culture puts on those areas. Here's some interesting writing about these different ways of thinking. When Sidney Blatt did his original research, I originally misunderstood what the sort of take-home message is. I thought it was that people who were the most mentally healthy were sort of in a midpoint in terms of being able to act autonomously and also give themselves up to the needs of the group, be selfish and also be self-sacrificing. And that isn't exactly what he found. What he found was that the people who tested the healthiest on a whole range of measures were high on both ends. They were capable of pursuing their own objectives and speaking for themselves. They had a voice, and they were able to completely lose themselves in relationship, sacrifice for the greater good, put other people's concerns before their selfish individual concerns. So that's a very interesting finding, I think. We are often helping patients if they have one but not the other, like the very dependent patient needs work on self-definition. The very narcissistic or psychopathic patient needs help in thinking about the other. All right, issues of diversity, which are certainly related to issues of having a feel for whether your overall culture is more collectivist or more individualistic. There is a lot of effort these days on teaching cultural competence. And again, I think the literature of competence is somewhat problematic. But here's another area that I put in the objectives. One of the ways we help supervisees when they're working with somebody who's quite different from themselves in any one of a number of issues, maybe it's their sexual orientation, maybe it's their sexual or gender identity, maybe it's their cultural background, maybe it's their religious framework or spiritual orientation, maybe it's a difference of class and or money, gender. There are infinite ways in which we differ from each other, and we can be wrong about what we leap to in terms of understanding the other person. So it certainly helps to read up on relevant knowledge. If you have a patient from, for example, I started treating a man who was a very observant Hindu a few years ago, and so I read up on Hinduism and on cultures that are organized around Hinduism. More importantly, I think, though, you need to help the supervisee to understand how to ask the patient from a position of humility to teach them about that patient's experience. That can irritate the patient a bit. I think especially Black patients are probably so sick of trying to educate white people about systemic racism that they can't possibly get that question without at least feeling a kind of exasperation. But ultimately, you're trying to get yourself educated and allowing the patient the position of respect and dignity to teach you something, which is a critical part of psychoanalytic work. It's also critically important with supervisees, and this is very hard for them, not to be defensive about the probability that they've internalized some biases relevant to whatever is the patient's identity group. And if you don't want your supervisees getting into arguments with their patients that, oh no, they never had a racist thought, or it never occurred to him that a class difference, would be an issue. I'm colorblind, or I don't think about that. If their supervisees are going to be of help to patients who have differences, the supervisee has to be non-defensive about the fact that I probably am going to slip, or I probably have unconscious ways in which I've been influenced by the larger culture, and please point that out to me when you see it. Mentalization, Fonagy's term, I think is the main capacity that we're trying to develop in psychotherapists, the capacity to see other people, including different people, from a position of subject to subject, not subject-object. Vitality, I love Winnicott's quote, a person can be normal without being alive. I tend to find patients who are lacking in vitality the hardest people to work with. I'd rather have a paranoid rant a patient hating me than somebody who is completely dead inside. Joyce McDougall and Christopher Bolus both elaborated on a certain kind of patient that, you know, looks normal but doesn't seem to have any depth. So we want patients to find their vitality. I think Andre Green's writing about the dead mother is very relevant here. I mentioned before, it's important that we help patients to accept what can't be changed. Psychotherapy isn't just all about behavior change. It's about really taking in that, for example, you had a terrible trauma. You are never going to be the person you were before that trauma. Much as you wish that I could return you to who you used to be, you are going to become a person who has been traumatized but isn't as damaged, but you're never going to get back the sense of total safety that you had before the trauma. This kind of acceptance is critical to patients. The mourning process is central to psychotherapy. The acceptance of what can't be changed. And over time, as people accept, they forgive and they feel gratitude, the same way that cancer patients who face the reality of their terminal diagnosis sometimes tell you, now I enjoy every sandwich. Because when acceptance happens, then you can enjoy what is. Love, work, and play. Love and work are what Erickson quoted Freud as saying were the purposes of psychotherapy. Richard Sturba added that Freud said to him, and sometimes he would add, and enjoyment, of course, and play. I'm translating enjoyment as love, work, and play. And there is my late friend, Jaak Panksepp, whose book on affective neuroscience really opened up to our understanding the mammalian brain and the beautiful interaction between his neuroscience study of mammals and our own mammalian understanding of ourselves. His book, The Archaeology of Mind, he co-wrote with Charles Brenner's daughter, Lucy Biven. So he's been a real friend to psychoanalysis, and he has contributed a lot of literature about the critical importance of play, certainly to developing children, but also to adults. In all countries that have been studied, in all pre-literate tribes, in all societies, people find ways to sing together, to dance together, to have athletic competitions together, sometimes to do dramas together. Or in a mass culture like ours, we may go to a concert, we may go to an athletic competition as spectators, we may go to a dance program, but we need that kind of activation of certain parts of our brain. Let me stop the share here. And I'll come back to it in a minute. And I think this would be a good time for like a 5-minute bladder and snack break. I'll be back and turn to the question, back to the question of the future of psychoanalytic supervision. So I have 2:31. I'll be back at 2:36. Okay, I'm back. So, what is the future of this kind of supervision that I've been trying to describe, via which we try to foster in our students a lifelong habit of reflection, mature ethical sensitivity, the capacity for self-correction, realistic humility, openness to new learning, and ongoing assimilation of a vividly experienced range of internalized influences, a process in which we try to sensitize them to the unique elements of each patient's personality and situation, where we keep our eye on the big picture of evolving capacity rather than defining our job as a kind of temporary relief of measurable symptoms, where we expect them to move on from our example and find their own therapeutic and supervisory understandings and emphases rather than becoming our clones. That future depends on several factors, only some of which we as psychoanalytic clinicians can influence very much. A narrow group of academic psychiatrists and psychologists, supported by vast corporate interests, mainly insurance companies and big pharma in the United States, have come to dominate the mental health narrative. They have compelling incentives, economic, professional, and narcissistic, to undermine our version of commitment to the examined life, whether that is their conscious intention or not. But nonetheless, it's worth talking about what we can do to secure a future for our vision of psychoanalytic education. Let me go back to a few more slides. First, we need to revive and strengthen in the general mental health community the norm of psychotherapy for the therapist. This norm has characterized psychoanalysis from its inception in the self-analysis of Sigmund Freud, and it once characterized many other approaches to increasing patients' mental wellness. Gestalt therapists expected to go through their own Gestalt therapy. Humanistically oriented third wave therapists sought their own person-centered treatments. Family therapists set out to explore the systemic dynamics of their families of origin. Clinicians interested in group therapy joined process groups that would help them understand group dynamics firsthand, and so on. My Skinnerian colleague at Rutgers, Brenna Bree, used to encourage students to find one of their own behaviors that they wanted to change and put themselves through a behavioral treatment for it. Despite empirical evidence for the value of therapy for the therapist, the emergence and eventual domination of our field by both biological psychiatry and cognitive behavioral psychology, which have developed their prescribed treatments mostly in academic rather than naturalistic settings, have undermined this time-honored norm. Several of my recent graduate students have told me that as undergraduates, they went to a psychology professor, stated their intention to become a clinical psychologist, said that they assumed they would find value in having their own therapy in preparation for that role, and received a response something like, "Why would you want to go into treatment? You don't seem to have a psychiatric disorder." A central issue these days for psychoanalytic supervisors is how to help their supervisees make the leap into their own psychotherapy. Except in analytic institutes, few training programs now require or even strongly recommend personal therapy. The paradigm of the application of a technical protocol to a DSM disorder has won the day. More so than in the past, trainees are likely to assume when we encourage them to get into their own treatment that we are diagnosing them as defective. However tactful and non-pathologizing is our introduction of the subject. Moreover, because of the drying up of insurance support for longer-term treatments, It is more expensive than it used to be to get one's own therapy, and our students are often already having trouble making ends meet. We need to remind ourselves that there are numerous reasons why personal treatment is valuable for therapists, perhaps especially now. It can help them get mentally healthier and more resilient under the stresses of their emotionally demanding work. It can help them come to terms with their own areas of misunderstanding and limitation. It can help them manage the unexpectedly intense emotional reactions they find themselves having to their patients. But from my perspective, perhaps the most important argument for having one's own treatment is that otherwise one has no basis for the critical emotional conviction that psychotherapy is effective. Without that, how does one convey sincere hope? When relative beginners apply short-term treatments to discrete DSM-defined conditions and find that they don't work as well as their professors were confident they would, they have nothing to fall back on, no personal experience of what really makes a difference. When their best skills fail, they feel impotent. Their disappointed patients devalue psychotherapy itself, and they devalue themselves as clinicians. So this area of the therapist's analysis or therapy requires constant attention and reinforcement inside and outside the field. The destigmatization of psychological suffering, which has proceeded swiftly over the last decades, should help with normalizing therapy for the therapist. But despite progress in this area, contemporary students seem to me to be under the misapprehension that they are supposed to be paragons of sanity already. The psychoanalytic assumption that we all struggle mentally and can use assistance throughout our lives is not often voiced by enthusiasts for the current paradigm. How can we stand for this idea in the world beyond our institutes? I have found that the value of therapy for the therapist is best conveyed to trainees by supervisors' self-disclosures about how much they learned and grew from their personal treatment, with clinically apposite examples, including comments about how much they still draw on their own experiences as patients when they now face a clinical dilemma as therapists. Such disclosures are much more persuasive than institute rules or empirical studies of the value of the therapist's treatment. Second, even though most of us are not by temperament interested in following and evaluating empirical research, we need to know enough about it to effectively counter arguments that there is no evidence base for the psychoanalytic therapies. This is the Orwellian big lie that we are currently up against. We need to educate ourselves enough about empirical research to talk back to misrepresentations of it. Although most psychoanalysts have come late to conversations about scientific evidence, and although our own arrogance about what we don't need to know has set us up to feel impotent when challenged to provide empirical grounds for our analytic claims, there is a small, indefatigable cadre of psychoanalytic researchers who have slowly been contributing to the scientifically respectable evidence base of psychodynamic treatments. It behooves us all to be able to refer supervisees to those resources. It can be eye-opening for those supervisees to discover how extensive is the empirical research supporting psychoanalytic concepts and treatments. Each one of those 10 vital signs, for example, had an empirical body of knowledge behind it. Third, we must seek common cause with therapists of other orientation. Despite the fact that many CBT treatments originated in the psychology laboratory rather than in clinical experience, cognitive behavioral therapists live in the real world just as we do. They face patients with complicated problems and unconscious resistances. They make warm alliances with them and work collaboratively in open-ended treatments with goals that are more ambitious than temporary symptom reduction. There are many theorists, researchers, and practitioners who are interested in integrations of CBT with psychoanalytic work. The Society for the Exploration of Psychotherapy Integration has a burgeoning membership worldwide. In practice, many of our psychoanalytic colleagues refer patients for adjunctive work with therapists of other orientations. We cannot in this context act out our sense of superiority to non-psychoanalytic professionals without cutting off the slender limb of the mental health tree to which we are currently clinging. In this spirit, let me share with you an email that my cognitive behavioral colleague, Milton Spett, sent to the multi-orientational New Jersey Psychological Association listserv a few years ago in response to another psychologist's email about yet another effort by insurance companies to limit treatment by reducing out-of-network coverage. I'm quoting here. If Bob is right, this would be a shame. I am currently treating a patient who has suffered with major depression, was socially isolated, never had a girlfriend, and was stuck in a dead-end job. In the past 6 months, he has made enormous progress. He has gotten off addictive drugs, developed several good friendships, received a big promotion at work, and has become engaged to a very nice woman. In addition, he has stopped missing and coming late to sessions. Not bad to accomplish all that in a 6-month period. The only thing is that this 6-month period occurred in the 7th year of his treatment. Then he adds self-mockingly, short-term CBT? Many people benefit not only from psychoanalytic treatment, but also from exposure therapy, DBT skills training, yoga, meditation, EMDR, somatically oriented trauma treatments, psychopharmacology, 12-step programs, and other specific interventions. I want to be clear that just because I am emphasizing the value of psychoanalytic work and arguing for a distinctively psychoanalytic version of supervising trainees' clinical development, I am not devaluing other ways of helping people. The analytic community has needlessly isolated itself because of our tendency to position the help we offer as mutually exclusive with or superior to other approaches rather than as potentially synergistic with them. Our concept of supervision is ambitious and comprehensive, but to stand for that ideal does not require us to diminish the value of other training. Fourth, we must become familiar with developments in neuroscience. This area is currently awash in the excitement that once accompanied the discovery of the Freudian unconscious. I'm pretty sure that neuroscientific terminology will be the language we will all eventually be speaking. Neuroscience is clearly the latest thing in our field, and we inhabit a culture in which the latest thing carries a lot more weight than received wisdom. When psychoanalysis was the latest thing, it made a huge impact on the culture in general, so much so that Auden's poetic tribute to Freud depicted him as, quote, a whole climate of opinion. Those days are gone and will not come back. The brain, not the psyche as we've come to know it, is the hot area these days. But we can take comfort in the fact that most neuroscientific findings have not been by any means antithetical to what analysts have learned over decades of listening to people and following their free associations, dreams, resistances, transferences, and enactments. For one thing, neuroscientists keep finding more and more evidence of unconscious processes and of the primacy of affect. Eric Kandel, the Nobel Prize laureate neuroscientist, has repeatedly stated that psychoanalysis offers the best account of human psychology. In this context, let me recommend Mark Solm's recent book, The Hidden Spring, for a fine introduction to neuropsychoanalysis. I can't conclude this talk without offering a couple of reasons for optimism. If we stand unapologetically for the norm of therapy for the therapist, learn enough about empirical research to describe our work as evidence-based, rather than arguing that we need no empirical evidence for the value of psychoanalytic therapies. If we find common purpose with colleagues of other theoretical orientations and treat emerging neuroscientific models of mental functioning with curiosity and excitement, rather than with the defensive attitude of we already knew that, even when we did, then I think psychoanalytic supervision will survive. It will survive partly because other approaches are running into their own natural limits. The experience of Sweden is pertinent here with respect to short-term evidence-based therapies. In 2015, the Swedish National Audit Office released a report about the outcome of the massive investment that leaders of the Swedish government had made several years previously at the urging of certain academics in cognitive behavioral therapy to the exclusion of all other psychotherapy approaches. These officials had allocated vast sums to training clinicians in CBT. The conclusions of their auditors were, first, that the widespread adoption of CBT methods had no discernible effect on the outcomes of people disabled by depression and anxiety. Second, that a significant number of individuals who were not disabled at the time they were treated with CBT alone became disabled, requiring governmental support now that they had a disability status. And third, that nearly a quarter of people treated solely with CBT dropped out of treatment. The current situation of biological psychiatry has run into a kind of natural limit as well, especially with respect to its failure to deliver on the promise of significant progress for people with severe mental illness. Despite over 40 years of policy dictating that patients with psychotic diagnoses be treated not with psychotherapy, but only with medication and management, that is, efforts to ensure medication compliance, and despite energetic promulgation of the empirically unsupported belief that people diagnosed with schizophrenia and other psychotic conditions need only to have their putative chemical imbalance rectified, there has been no reduction in psychotic suffering or its long-term consequences. I refer you to the recent book, Healing, a lament by former NIMH director Thomas Insel. Instead, our streets have become more or less permanent residences for many psychotically troubled homeless people, and our prison system has replaced the mental hospital for those whose demons instigated their acting out. Over-medicated people dealing with private madness are now struggling with drug-related obesity and diabetes as well, and they are dying as young as they ever did. Nancy Andreasen's research group reported a few years ago that there is as much damage to the brain from years of neuroleptic medication as there is from untreated schizophrenia, making talk therapy for more serious psychological conditions an urgent matter. I want to emphasize that I think cognitive behavioral therapies and pharmacological therapies are both valuable and sometimes even life-saving. But as a substitute for insight-oriented psychotherapy, their effects are limited. One of our jobs as supervisors is to help our supervisees evaluate and counter the misinformation about psychodynamic treatments with which they are still showered and point out the failures of less far-reaching fixes. I would like to believe that this is easier to do now than it once was, as we are all waking up to the damage done by collective fantasies that we can, quote, do more with less in the mental health field. Second, psychoanalytic supervision may survive because people naturally seek to grow and learn. Psychoanalytic pedagogical premises are respectful of that reality. Moreover, the psychoanalytic emphasis on relationship conduces to the safe attachment that fosters the expression and elaboration of what James Grotstein called our truth drive. Notwithstanding human resistance to painful realities, this will to understand and make meaning is the prime driver of analytic treatment and training. Psychoanalytic supervision will survive because our supervisees see that their patients do better in response to analytic mentoring, just as psychoanalytic therapy will survive because patients who undergo it experience its positive effects and recommend it to others. Whether it will survive within our mental health system, however, is another story. I'm pretty sure that traditional intensive on-the-couch psychoanalysis will not endure there, that eventually it will be an approach limited almost entirely to psychoanalytic candidates, the very wealthy, and a few people in artistic, philosophical, spiritual, and literary communities. But that doesn't mean that psychoanalytic supervision has to die. Individuals training to be therapists will continue to learn that the most thoroughgoing immersion in their own and their patients' psyches provides the most personal and professional rewards. I believe there is no better preparation for doing psychodynamic therapy, and arguably for doing any other kind of meaningful therapy, than analytic training. It is a great blessing to our community that a psychoanalytic perspective makes any kind of human interaction potentially interesting. Let me return to Roy Schaefer, to some observations he made when keynoting a graduation dinner at the William Allenson White Institute. I have taken the liberty of substituting psychoanalytic supervision and supervisee for the terms analyst and analysand in this quote, because the growth process he depicts applies to both. Quote, "It only sounds paradoxical to say that that in doing psychoanalytic supervision, we help people realize that things are a lot more complicated than they ever dreamed, and that there is something liberating about realizing that this is so. This realization is liberating, even if the supervisee does not have everything very neatly, consciously, and verbally synthesized at the end of training. In fact, one would have some reason to mistrust too great a sense of order at that time. In reflecting on the unending effort involved in becoming an analyst, one can only gain empathy for the supervisee who is also interminably undergoing change and facing ever more directly the uncertainties, the hazards, and the opportunities of existence." Thank you for your time and attention. And at this point, we can go to conversation.
Nancy, there's a question here that has a little bit of background that I'll read from the comments here. And it just topped out of view. So if you give me a chance, I will scroll back to it. It had to do with and this is from Eileen Griffin. In listening to the first portion of your lecture, I've been thinking about instances of psychology training programs pathologizing the anxiousness of trainees. One case where a student was written up with a warning for being too anxious with clients, and another case where a cohort was labeled as the anxious cohort, and their concerns and requests for more information met with eye rolls by faculty. However, at least some level of anxiety is understandable and expected from trainees. I'm wondering if you can speak on addressing the anxious dynamic with supervisees, helping them through that developmentally, and where the line is of a supervisee being, quote, too anxious to the point of needing intervention from a training program.
Let me take the last part of that first. I can't remember a student who I thought was too anxious to work with patients, but I think the criterion would be if the person, you know, were shaking visibly and unable to talk or listen, because it's realistic to be anxious about becoming a psychotherapist. Anxiety is part of what's inherent in being a therapist or a patient. And I think the best we can do for supervisees is support their own capacity. I think it's easy to misunderstand just how vulnerable somebody who's starting out feels. I remember feeling absolutely skinless when I was a beginning therapist. And you sometimes get in supervision a kind of mismatch where the supervisor feels this need to teach something, because their self-esteem is predicated on, I have to have something to offer here. But what the supervisee needs is basically the message, you're doing okay. You know, your basic instincts are pretty good here. You know, if we find ourselves being critical, framing it in terms of, I think I would have done that differently, and let me tell you the reasons, but I understand that I think why you did what you did, and it makes a certain sense. But here's an idea for you, just in case this makes more sense to you. It has for my patients. You know, that kind of normalizing of, yeah, this is tough work, but you have the chops for it, you know? I don't see any evidence that you can't do it. Is a message that is realistic and never hurts the supervisee. You never want to make supervisees become more anxious. You want to help them feel safe the same way you want to help patients feel safe. So that's a pretty terrible story, the anxious cohort. I hope that wasn't my program. Anyway.
That's actually the only question. There are a lot of observations. One has to do with polyvagal theory being magnificent neuroscience for working
Oh,
with
yeah. Yeah, that's wonderful stuff.
someone gave you kudos for taking on the ridiculous educational objectives topic. And there was also a boost to Jonathan Shedler for sharing many compelling tidbits from your new book and for publicizing this lecture.
Oh, did he really?
That's what it says in the comment. Yeah.
Oh, I got to thank him. I was thinking of sending him this lecture ahead of time, but he and I read each other's stuff a lot, and I didn't want to burden him too much. But that's very sweet of him. We are a mutual fan club of each other's work. We're of this small minority of people trying to talk to the larger community defending psychoanalysis. He just gave an interview on NPR that I heard a few weeks ago that was just wonderful. He said, the model that is being purveyed is not medicine. It's like first aid. If you can stop the bleeding, you've done the job, which I thought was a beautiful metaphor.
Whitney Van Nauheis, I think I murdered her name, said that as a community, we also need to commit to uncovering biases in our theories that limit relevance for various classes of clients.
That's an ongoing process. If you look back over old psychoanalytic literature, you absolutely cringe at the assumption of the white, male, heterosexual, middle to upper middle class, Western, and often secular assumptions that are just taken for granted as the true way. And I think part of our job as evolving professionals is to just get corrected more and more about the things that we take for granted. I recently supervised a trans person on a trans patient, and I kept slipping, and I hurt the presenter, really disappointed them. It's been hard for me to learn to use the pronoun them, despite my wish to be respectful of what people want themselves to be called. So, I feel like I am now in a position comparable to my teachers back when I was so offended if they referred to people my age as girls, which was common at the time, the girls in the class and so forth. So I hate doing that to people, but we just have to listen and get better as we're able and apologize when we screw up on those areas.
There's a couple of other questions that have come in as well. One person, Ajita Agarwala, is a therapist from India who's benefited a lot from your work in particular. He says he finds myself at a loss when it comes to resources and training opportunities in psychoanalytic work, and is asking what your thoughts are on resources that might fill this training gap in the interim.
There are some distance psychoanalytic institutes, and there are some countries not too far from India where there is psychoanalytic training. I would recommend that you start a psychoanalytic training program in India once you get training from one of those other sources. It's interesting, the spottiness of psychoanalysis. It's huge in China now. It's undergone a huge resurgence in Russia. It's very strong in Iran, in the Scandinavian countries, in some places where you wouldn't expect it, and not so supported in some places you might expect it. So I'm not sure what to tell this man other than to talk to people who have started psychoanalytic training programs in countries that did not have them before. That's much of Eastern Europe at this point, because they had to reinvent psychoanalytic training after years of it being forbidden by the Soviets. You couldn't read Freud. It was forbidden from 1923 on until Perestroika. And that affected all of Poland, all of, Latvia, Lithuania, Estonia, the whole Eastern European area.
There are a couple of participants that have indicated they have questions, but they didn't state what the question was. If I could call on them to directly ask that question, I would first start with Suzanne St. John. You said you had a question regarding narcissistic vulnerability of supervisee and supervisor.
Hi, Nancy. Thank you so much for your lovely talk. I was wondering, as a chair of a program and at an institute where I am teaching psychoanalysts and psychoanalytic psychotherapists, the essential aspects of supervision. I was wondering whether you could talk about the narcissistic vulnerability of the therapist and the patient to therapist relationship, to the supervisee, supervisor. I feel that the narcissistic vulnerability is quite and elements of one's superego are really quite powerful forces in the supervisory process.
Yeah, I think supervisors can be much more hurt by supervisees than the supervisee knows. And it's partly because it's such a relief to have an hour with a supervisee. You don't need to exert quite as much discipline as when you're in it with a patient. This is a colleague. You feel like you can talk more frankly, and you're kind of expecting your own self-esteem to be supported by the supervisee's gratitude for what you're offering. And sometimes the supervisee has painful things to teach you, or doesn't like what you said and has to process that. And it can be disappointing in a way that feels worse than it is in therapy, where you can sort of, put that off to the transference of a person who's deep in a transference process. So supervisors are vulnerable. Supervisees are exquisitely vulnerable. They do feel skinless, and they have, even if they've chosen you, they've put you in a position of great power psychologically over them. One of the interesting things about, they're finally doing research asking supervisees, not just supervisors, about the supervision process. And you may be aware of some studies out of Norway that found that supervisees keep things from supervisors much more than supervisors think they do. and it's often things related to diversity and difference, and the expectation to be pathologized for something. It seems to me that the main thing a supervisor has to do, the first thing, is to try to make the supervisee as safe as possible, saying everything or imagining at least talking about themselves. I'm very careful with supervisees not to ask them about personal information, but I love it when they volunteer it. And I will say that at the beginning. I'll say, you know, it's not my job to inquire about what kind of psychological struggles you've had or what kind of trauma you've gone through or what your sex life is like or anything like that. But I'm hoping that over time, you'll become comfortable enough with me that when a patient activates that kind of thing for you, you'll be able to talk about it without the worry that I'm going to pathologize you. And I have had supervisees who have told me after a while that they are a recovering alcoholic, or that they were a sexual abuse victim, or that they were, you know, picked up for shoplifting as a teenager, or any one of a number of things like that. But I don't think you can underestimate how vulnerable supervisees feel and how much it's in their interest to be sure they don't offer anything that's going to get them pathologized. I think probably the worst habit of psychoanalytic training programs is to talk about people diagnostically instead of talking to them about their behavior. So it's a different, when we're talking about students, for example, we should try to exert a discipline where we don't say, I'm worried about Mary's narcissism, because that's going to get back to Mary and be devastating. You want to say, it seems to me that Mary sometimes talks about herself in a way that distracts from the patient's process. Okay? And when you're talking to Mary, that's how you want to frame it. When you said that, here's my worry, that it got your patient derailed in some way. You don't want to say, oh, your narcissism got out of control there. Okay. You don't want to substitute diagnosis for just descriptions of actual behavior and verbalization.
There's two other people indicating they have questions. I'll go first with Cheryl Rothery.
Oh, hi, Cheryl.
Hi, Nancy. Good to see you. Wonderful presentation as usual. I just thought, and this is going to be a small, short comment, and I hope that I don't get beat up on for it, but I'm a training director of a doctoral program. And so the comment that was made a few minutes ago about anxious students and anxious cohorts, I agree that there is a lot of anxiety, and should be, because the work that we're training students to do and that they're training to do is very, very important work. What I think becomes problematic, though, is how the anxiety manifests. You were speaking just a second ago about behavior.
Mm-hmm.
And so when you have behavior that is focused more on the outcome, say the grade, instead of the learning process, or is this going to be on the test, or questions like that, that one might expect from students much younger in their educational career, it makes the anxiety feel other than what it should. It doesn't feel like healthy anxiety anymore. It begins to morph into something else.
Mm-hmm.
And so I think that may be what's happening for some students and training programs. So I just had to give a shout out on behalf of training directors who are training students.
Point taken. It's a good point.
Different generation for sure. So
yeah.
But it's great to see you.
You too.
Ben Morsa, you had a question as well.
Sure. Hi, Dr. McWilliams. Always really great to hear you speak. I think your second edition of Psychoanalytic Diagnosis came out in my first year of graduate school. And now in my first year, having a true long-term supervisee who's an associate in my practice, your book came out, or I became aware of it just weeks before starting with this person. So I know you have some appreciation for Jungian synchronicity.
I do.
The question I have is, one of the things I've always appreciated about your work and your practice of communication about psychoanalysis is your emphasis on our need to do research and to sort of play along with others, which is, not what you said, my language. One of the things I find in my own career is someone who was really interested in research, but chose to go to a program that emphasized analytic clinical training much more, is I now find myself working with populations where finding a therapist who's experienced, who isn't going to misgender them, is like not necessarily a given, which means I'm fairly overwhelmed with like clinical demand. And I suspect a lot of folks are. So I was wondering if you could offer any perspective on the ways that clinicians get so deep into the work and that becomes in such demand, and where's the bridge to bring that into research and offer this connection you're calling for?
Boy, I'm not sure. I think that you've got about 5 potential doctoral dissertations in what you've just brought up. I mean, you could start by doing qualitative research, interviewing people about their experience. And what you're talking about is, I've been aware of it, not so much around issues of identification and gender flexibility and so forth. But for a while, I felt terrible watching my African-American students be overwhelmed with referrals of African-American patients. And the students often had sacrificed terribly to get their education, and these were almost always low-fee patients, and they felt so keenly the need to be there for this community that they got easily overwhelmed. It sounds similar to that, and it strikes me that it's similar to what people are suffering now during COVID. Just about everybody I know has no openings these days. I can't find people to take patients recently, even people who don't have trouble paying for ordinary rates. So I think we're seeing a terrible mental health crisis. I think it's not unrelated to what we've done to mental health that we're seeing that way. I mean, these college shoot 'em ups that have happened, just prior to everybody going into quarantine. I've often wondered whether they would, often the people who go off and, mow down their classmates have a pretty difficult mental health history, but it's this medication and then that medication and then this short-term treatment and that short-term treatment. I'm thinking, if there'd been somebody in the counseling center that had just been available to them over, with some continuity, I wonder if that would have happened. I don't know if that's empirically researchable, but Jonathan Shedler is an empirical researcher. I am not. I just try to be a good consumer of empirical research. And Jonathan tells me that you can research just about anything if you figure out the right way to frame the question. So I want to support that side of you, that I think you're not at all untypical, that most of us, when we go through training programs, we want to be therapists. We're interested in research, but we didn't want to be researchers. That's an unusual temperament. But it's a good idea to make connections with people who are in that field and keep telling them what clinical experience is really like. Otherwise, they're going to be studying stuff that's easy to study, but doesn't have much relevance to us. So I guess that's all I can say is you go.
I appreciate that. Thank you.
There's another question that's kind of on a practical level. When encouraging supervisees to seek their own analytic therapy, There often seems to be cost barriers, as this is not covered by insurance,
That's right.
often lower paid, newer therapists. Do you have any advice for folks who are eager to engage but experience cost barriers to obtaining their own analysis and analytic therapy?
Well, I think your institute offers some low-cost treatment, right? My institute in Central Jersey does. I tend to send my graduate students there because very often their candidates want somebody who really wants to do intensive psychoanalytic treatment, and they will reduce their fee pretty far in order to work with a person who really has the heart to go into the deep work. That's one approach. Another one is constantly fighting with insurance companies. Insurance companies will cave if you bring out all kinds of big guns and make all kinds of arguments about need and so forth. But there's a downside to that, namely, you have to have a pretty stigmatizing diagnosis in order to persuade them, and then that's on your record forever and so forth. But there are many clinics where they try very hard to offer low-cost treatment. In most cities, you can find analytic institutes that will take people like that. And these days now, with remote treatment being acceptable, even if you don't live in a city, you can find somebody. Maybe you'll have to be on a waiting list for a while, but that is a real life serious problem. I got my analysis back in 1969 to the mid 70s, my first analysis, and my insurance paid for the whole thing 3 times a week. Without question, that was what it was like back then with the kinds of insurance that we had. And I think it was more cost effective than what we're doing now. But that's another argument.
From David Miranda, would you please comment about Karen Moroda's observations about the greatly increased number of non-physician women who are now psychoanalysts and their influence on the future of psychoanalysis?
Is that from Karen's recent book?
David, you would have to speak to that.
The Analyst's Vulnerability, that one?
I think the question came from me. I'm George Strutt. Happen to know David and would be glad if he got credit for the question. But this is something that I've been wondering about a lot. Karen Moroda, a psychoanalyst, I believe
She's
from
a friend of mine.
Minnesota, has written a number of articles concerning the importance of the taking into the psychoanalytic profession of all these non-physicians, and particularly women that were not psychoanalysts, let's say, prior to the 1980s.
Right.
And how this, if you will, change of personnel has helped to foster the two-person as opposed to one-person relational psychoanalysis that we're now speaking about. And so, and on the other hand, fewer male psychiatrists who are less bringing an authoritarian, what you might call teaching emphasis. And I'm thinking about that with respect to the future of psychoanalysis, and particularly the future of psychoanalytic supervision, to the extent that that would emphasize more, if you will, the holding environment. That's Karen Moroda's emphasis.
Yeah, I think she's absolutely right about that.
Okay.
However, there is a downside in the fact that psychoanalysis has feminized to a degree, and that is that every profession that has feminized has lost status over time. You know, secretaries used to be men, nurses used to be men. As they feminized, their status went down, the salaries went down. The same thing's happening in psychoanalysis. And that that's the downside of it. But I do think, you know, and I'm a pretty good exemplar of somebody Karen's age. That's how she pronounces her first name, by the way. If you ever have a personal connection with her, it's Karen Marotta.
Karen. Okay.
She and I are sort of the same cohort and watch the same changes happen. It used to be at the Division 39 meetings, it was, you know, 17 men and 2 women, and now it's like 17 women and 2 men.
Right. Well,
Or 10 women, 6 gay men.
yes, to take up your point
And
about
1 or 2 heterosexual guys.
the importance of the limitations of other paradigms, we can easily talk about the limitations on the paternalistic, authoritarian approaches, not just to treatment, but to relationships.
Yeah.
That yes, give psychoanalytic treatment and supervision a whole different cast and quality, but even future in a positive way. But I understand your point about, but it's lower status.
Yeah. Well, one of the things that I always admired about psychoanalysis was that it was the first profession I ever knew about in which women had a status equal to men. Meaning, you know, you can say what you want about the ways that Freud may have gotten women wrong, but he was very respectful toward women. He took so-called hysterical women that everybody else was devaluing and listened to their experience and let them teach him what worked for them. He encouraged his daughter into the field. He had warm relationships with other psychoanalysts like Sabina Spielrein and Lou Andreas Salome and the people of his era. And by the time I came into psychoanalysis, women were appreciated not just as equal analysts, but as theorists. We had Melanie Klein, and Karen Horney, and Frieda Fromm-Reichmann, and I saw that in no other profession at the time. So it has always been a welcoming place for female professionals, and female professionals are to some extent making it over in a somewhat more traditionally female concern with attachment, relationship, and so on.
Yes, and I understand that Freud was actually an enthusiastic supporter, at any rate, a supporter of women having the right to vote. At the same time, right, all that was going on, women having the right to vote, and Freud was for it.
I'm not surprised.
Yeah.
Okay, we better, I guess we're getting to the time boundary, right?
I think
Hey,
you're
Neil. I just saw Neil
Hey,
Skolnick in
Nancy.
the audience. Hi there.
Hi, listen, I'm butting in here because I've been trying to send a chat message. I'm totally Zoom compromised. I have no idea how to do it. So I'm just going to butt in and say thank you, Nancy. This was wonderful. And your ability to integrate respectfully knows no peer. It was really enjoyable. Thank you so much. I enjoyed it all, and I'm just noting that. Good to see you.
Thank you for having me. And I have, with the corner of my eye, been keeping a track of some of the comments in the chat, which are very helpful and useful to the rest of you too. So pay attention to those. People have been offering things in the chat. Just hit the little chat emblem on the bottom.
Thank you so much. Everyone is saying thank you, but we will say it one more time on behalf of our institute and what a friend you've been to us over the years, and we really appreciate your sharing your wisdom, your candor, and your optimism about the inherent desire of people and to seek learning and growing, and how we have that for us, and how we have to find ways to advocate for the people who really want what we're doing and help them make sure that it's there. In Nancy's preface to the book, she said that she warned that she thought she might have written her her last textbook, and I have a note to say, I hope you break that promise, but that's a promise I think you should have permission to break. And blessings to you all, and blessings. Thank all of you for joining and for your wonderful attention, engagement, and questions. And be well and stay optimistic.
Thank you very much. Thank you.